to the 2024 pathology exam. Question 1. Musonda is 35 years old woman from Lusaka. She presents to the clinic with complaints of general feeling of being unwell, yellow eyes, and a headache for 2 weeks. Her liver enzymes are elevated with AST 100, ALT 200. HPSA antibodies. HPS antibodies is positive. The patient later developed confusion, which progressed to stupor, a stupor, and then a coma. 2 weeks. So classify jaundice. We know what happens for normal metabolism is, let's pick it up from where you have got hemolysis of red blood cells. When we have got our red blood cells, when red blood cells are broken down, red blood cells have got hemoglobin. So hemoglobin is going to be released. The breakdown of hemoglobin, because hemoglobin is made up of heme and the globin. Globin is going to be released, and then the heme is further going to be broken down. And that heme is, when it is broken down, is going to be broken down to biliverdin. And you're also going to have the release of iron and carbon monoxide. And later on, when the biliverdin can then be also converted to bilirubin, that bilirubin can be conjugated by the liver, and that is going to be normal. But for now, so we are saying where, because for us to release at the end of it all bilirubin, we need to break down red blood cells. So where can you break down these red blood cells? You can break down the red blood cells before the liver. So here is our liver here, and we know from the GIT here, you are going to have, of course, this is structure, the bioducts, and then they're going to connect and then come to drain here. You have got veins that take blood to the heart. So breaking of the red blood cells can happen before the liver, before blood actually goes to the liver, and that is known as hemolytic jaundice. Hemolytic jaundice is actually happening before the liver, so it's known as pre-hepatic jaundice. And then we have got hepatic jaundice, which is now happening in the liver itself. And then after the liver, that is post-hepatic jaundice, and that is mostly because of obstruction to these structures here, the obstruction to the bioduct. And so that will prevent bilirubin from being excreted, and so it ends up to accumulate in the body, and that's known as post-hepatic jaundice. So I've got three types: pre-hepatic, hepatic, post-hepatic. Pre-hepatic is hemolytic. And then the hepatic, the one in the liver, that is also known as a hepatocellular jaundice. And then post-hepatic, that's obstructive jaundice. So the thing was just to classify, not just to talk about it even much details there. What is the likely cause of this jaundice? Provide a full description, diagnosis of the statement. So from what we've been told, 35-year-old woman, she presents to the clinic with complaints of general feeling of being unwell, yellow eyes, and a headache for 2 weeks. You can see there is also the elevation of liver enzymes. This is telling us that there's actually a problem with the liver. And if you can see possible causes of pre-hepatic jaundice, this is hemolytic jaundice, sickle cell anemia. Hepatic, you have got viral hepatitis, like the virus that can cause hepatitis, alcoholic liver disease, and also liver cirrhosis. Post-hepatic includes the gallstones, the tumor, and the stricture. But because of the elevation of the liver enzyme, this means that the problem here is there's actually the problem with the liver. And so the possible cause would be hepatitis. Yeah. So what is the likely cause of this jaundice? Hepatitis, which can be viral hepatitis, and it's acute. If a condition becomes chronic, there is more a compensation that happens. The other part of the question is saying provide the full description, descriptive diagnosis or statement of cause. This jaundice here, because we are saying it is hepatitis, the problem is the liver. Because of that problem with the liver, there's going to be elevation of the liver enzymes as we've seen. And so provide the full descriptive diagnosis. How can you diagnose the condition? The first thing of what we've already been given, the liver enzymes that are elevated. We can also look at what is known as the positive hepatitis B surface antigen. This been given in the question. So just that hepatitis, that is a virus that confirms also that this is viral hepatitis. And then we should also differentiate, for hepatitis A, B, and C. The B and C causes liver disease or liver carcinoma. So that also confirms that. And then the clinical presentation of the patient having jaundice and also some systemic symptoms of feeling generally unwell, headache, those are also confirming this diagnosis. Also confusion, stupor, coma, these ones are suggesting that there's actually involvement of the brain. Remember, if there is liver disease, ammonia is not going to be converted to urea, which is less toxic. And so the accumulation of ammonia can go to the brain, causing hepatic encephalopathy, and this is what causes this confusion, the stupor, and the coma. Part C of the question is saying, what is the mechanism of cell injury induced by the cause of jaundice in this patient? So, what is the mechanism of cell injury? How does the this is caused by the jaundice in this patient. So, how does this jaundice actually injure the cells in this condition? And we have just confirmed that because of the diagnosis we've given, this is viral hepatitis caused by hepatitis B. So, how this can cause cell injury is they can be direct viral cytotoxicity. The hepatitis B itself can infect the hepatocytes, and that can lead to their damage and then their death. At the same time, you can have an immune mediated injury because the immune system is going to be trying to respond to the virus, and there's going to be release of a lot of these cytotoxic T cells that could be able to attack the liver cells that have been infected, and that can lead to the death and the dysfunction of the liver. And then D is saying what are the possible outcomes of this patient's condition, short term and long term. So this patient has got viral hepatitis. In short term, if you treat the condition, there can be recovery. And it can as well be another possible outcome can be the acute liver failure. The liver can end up failing. And this is acute because it is a short period of time. But over a long period of time, there can be chronic hepatitis due to the hepatitis B. They can also be liver cirrhosis if the condition stays there, and it can also go into hepatocellular carcinoma because at this point there is just inflammation. It's an acute inflammation of the liver, but if you let it, it can lead into liver cancer. He is saying what is the explanation for the patient's confusion, stupor. We already talked about this. We said because the liver is not converting the toxic ammonia to urea, ammonia accumulates, and when the ammonia goes to the brain, it leads to hepatic encephalopathy, and that is what leads to these symptoms. The patient is concerned about aflatoxin. Explain what disease aflatoxins are associated with and how they cause such a disease. So aflatoxin, this is a product that comes from the breakdown of different substances. Okay, it's a toxic product of fungi, especially Aspergillus flavum and Aspergillus parasiticus. These are these are fungi, and these guys, when they produce the aflatoxin, it is going to infect the food that we eat. For example, actually contaminate, not really infect, because infection is us getting the microorganism. So contaminated maize, peanut, tree nuts, all these guys, we can consume them, and when we take them in, they can lead to hepatocellular carcinoma, liver cancer. And the other part of the question is saying, explain what disease aflatoxins are associated with and how they cause such a disease. So how are you going to cause liver cancer? How do aflatoxins do that? Aflatoxins can cause DNA damage, and that can lead to mutations and genetic damage. Aflatoxins can as well cause oxidative stress. So this oxidative stress that is caused is going to cause cellular damage. Remember, in the liver you have got the organelles. Like organelles like the mitochondria. Actually, the accumulation of different substances in the in the cells can cause these cells to overwork. Like for example, the mitochondria, because it's actually the one that is involved in oxidative phosphorylation. So there's going to be stress, and so it can lead to the damage of these organelles, and that can actually also, besides this cellular damage, there can also be the promotion of carcinogenesis, the production of these carcinogens, these harmful products that are able to cause cancer because of just oxidative stress. Aflatoxins can also induce immunosuppression. When the immune system is suppressed, the body cannot be able to fight infections, and so that would be the same with cancer. It can easily form. Are we okay with this part of the question? There is any addition or question? It's okay. Question number 2. A 32-year-old male of Chawama compound present to the UTH adult hospital with a productive cough of 4 days duration, chest pain, fever, easy fatigability, and difficulty in breathing. He is a non-chronic alcoholic and works on as a bus conductor. Diagnosis of pneumonia is made. Classify pneumonia according to anatomical distribution. No, pneumonia is an inflammatory condition. It's one of those few inflammatory conditions that don't end in itis. So how you can classify pneumonia anatomically? You look at what region is affected. So you have got the lobar pneumonia. It involves one or more lobes of the lungs. Bronchopneumonia is characterized by patchy consolidation around the bronchi and the bronchioles. Interstitial pneumonia, which involves the interstitial tissue of the lung. Remember, if you have got this as your alveolar, you have got a surrounding tissue there. Okay, so it's going to involve all these regions, and that is going to lead to diffuse patchy inflammation. So three forms of the anatomical classification: lobar, bronchopneumonia, and interstitial pneumonia. List 5 causative agents of community-acquired pneumonia. In the community, we have got all these bacterias, the fungi, and these other microorganisms: Streptococcus pneumoniae, Haemophilus influenza, Mycoplasma pneumoniae, Chlamydia pneumoniae, Legionella species. These can all cause pneumonia in the community. And list etiological factors of acute respiratory distress syndrome. Respiratory distress syndrome is where this is acute. So suddenly someone is failing to breathe well. Or maybe there's an obstruction to the respiratory system. So what can cause that? Sepsis. If you have got bacteria going throughout the bloodstream, that can result into this acute respiratory distress syndrome. Severe pneumonia, aspiration of gastric content. You are trying, the contents in the stomach get to go back via the esophagus, and then they end up going to the respiratory system. That can cause difficulty in breathing, so there's going to be respiratory distress. Also trauma, like to the chest, that can as well cause difficulty in breathing, that can result into the acute respiratory distress syndrome. And then inhalation of harmful substances like smoking, chemicals can as well result into the acute respiratory distress syndrome. List complications of pneumonia. So since pneumonia, we said this is an inflammatory condition, what we are going to see is because of inflammation, there's going to be accumulation of different fluids. Remember, where there's inflammation, a lot of cells go there. So that leads to pleural effusion. There can be an abscess. Abscesses are formed when there's accumulation of cells in a region, and then these are covered. Acute respiratory distress can as well happen. Sepsis, because this is inflammation. There is actually a bacteria that you are trying to surround. As we have said, different types of Streptococcus pneumoniae. If it is there, this guy can actually get to spread through the blood, and that causes sepsis. There can also be respiratory failure. That is one thing that you are afraid of happening. Actually, most of the condition of the respiratory system, when they happen, the problem is that at the end of it all, they can all lead to respiratory failure, just like the conditions that affect the kidney. At the end of it all, they can result into kidney failure. Same with the heart. Write short notes on diagnosis of TB. So TB, we can use medical history and physical exam. You are going to assess symptoms, for example, a persistent cough, weight loss, night sweats. Of course, these are B symptoms, and fever. The physical exam can include checking for the swollen lymph nodes, because you have got what we call TB lymphadenitis. So what happens is that the mycoplasma tuberculosis can actually get to, besides it affecting the respiratory system, the other second most uh, extra respiratory region that it affects, or part that it affects, is the lymph nodes. So you can see swollen lymph nodes, and you can as well listen to the lung sounds because it's affecting the respiratory system. You can perform a tuberculin skin test. This is where you get a small amount of tuberculin, you inject it under the skin, and then you are now going to look at the reaction. So if someone has been exposed to TB, you are going to see a red area around, and then there's a bit of a reaction that has happened on that area, and that is a positive test. It means that you actually have the bacteria in the body. Interferon gamma release assay. So this is a blood test that measures immune response to the bacteria TB. So how is the immune system responding to the TB? So you can do this interferon gamma release assay. Can also look at the chest X-ray. Active TB is going to be identified by abnormality in the lungs. The sputum smear and culture examined under a microscope to detect the TB can also be done to confirm diagnosis. If you be able to see the bacteria, molecular tests can also be done, and this is where you want to look at the genetic part of the TB. Rapid tests, different types that you can also use. And then you can also do some additional tests, for example, in cases of extrapulmonary TB, like the TB that affects other regions, apart from the when the bacteria spread now to other regions besides the respiratory system. You can do other tests such as the CT scan, MRI, the biopsy. For example, if the lymph nodes are also involved, right? List 5 stimuli that can trigger asthmatic attacks. So asthma, allergens can trigger, for example, pollens, petty, dander, mold, dust, mites. So all these things we can respond to them, and that causes an asthmatic attack. Airborne irritants like smoke, pollution, strong odors like some perfumes, that those can as well get to stimulate an asthmatic attack. There's going to be bronchoconstriction. Respiratory infections also, for example, a common cold, a flu, these can also stimulate an asthmatic or trigger an asthmatic attack. Physical activity, there's what we call the exercise induced asthma, because when you're exercising, there's actually going to be there can be bronchoconstriction that can happen. Normally it's supposed to be broncho dilatation happening, but for asthmatics that can happen when someone is exercising, because at this point you need a lot of air to go in when you're exercising. But the problem is that the pathway to the lungs is constricted. Weather changes can as well get to cause the problem here, like cold air, humidity. When it is cold, there can be the asthmatic attack can be triggered. Is this okay? Any question or contribution? Number three, 62-year-old male with a history of hypertension, hyperlipidemia, and smoking presents to the emergency department with a sudden onset of chest pain that began while he was watching TV. Take note of the sudden onset here. That began while he was watching TV. He described the pain as heavy and notes that it radiates to his jaw and left shoulder. He has felt similar chest discomforts with exertion in the past, but this pain did not improve with the rest. Physical exam appears pale and diaphoretic with blood pressure of 140 over 90 and a heart rate of 105 hearts per beats per minute. An initial ECG shows ST segment elevation in the inferior lead. Laboratory results show elevated troponin levels. You can see troponin being involved, and then there is a sudden chest pain. So obviously you are thinking there is some involvement of the heart here. What is the most likely diagnosis for this patient, and what is the underlying pathophysiology of this condition? Most likely diagnosis, acute ST segment elevation myocardial infarction. So this is MI, a myocardial infarction, acute ST segment elevation MI, so STEMI. The underlying pathophysiology of MI, number one, there is sudden reduction or cessation of blood flow to a portion of the heart muscle. That's what we know. Maybe there is a blockage in one of the coronary arteries. And because of that, maybe, say, for example, what can cause that blockage of blood going to the coronary arteries? Maybe there is a rupture of an atherosclerotic plug. This is our entire body. And for the entire body, we have got these blood vessels. Say you had atherosclerosis. And when this ruptures, it is going to be taken to the heart, and then it will end up blocking the small arteries, like the coronary artery. And once those are occluded, and that is forming what we are calling, of course, when a thrombus breaks, that's known as an emboli. But to this atherosclerotic plug that has left is now going to end up forming a blood clot, a thrombi in these small arteries, and that causes blood not to be going to the heart, nutrients are also not going to the heart. That causes ischemia, so heart tissue or heart muscle begins to die. That leads to necrosis, and then there is the heart muscle getting to fail. So that is the underlying pathophysiology. Next part is saying, explain how atherosclerosis can lead to an acute myocardial infarction, include a description of plaque formation and the events that can lead to plaque rupture. We know atherosclerosis is where you have got a buildup of fatty deposits within the walls of arteries. And how it can lead to myocardial infarction, there's going to be the formation of a plaque, right? This is, you have got this. This plaque sometimes can cover the entire wall, the entire lumen, or not always. And why are you forming this plaque? Because of the accumulation of cholesterol, fatty substances, cellular waste, calcium, fibrin accumulation in the lining of the artery. These are going to get to power up forming this plaque. And this will end up narrowing the blood vessel. And then this plaque can actually get to rupture. Okay, because the surface, the point at which it is attached to the wall, becomes unstable because blood is actually coming to push against. So this ends up rupturing, and then the contents are exposed into the bloodstream, and that will trigger the formation of a blood clot, because anything that is moving in the blood that is foreign might actually just trigger, for example, the intrinsic pathway, because there's actually going to be this can cause injury to the endothelium, and that is triggering the blood clotting cascade. And then there's going to be the formation of the thrombus. The blood is going to clot and then to quickly and completely block the artery, and this blockade prevents the reaching of oxygen to the heart muscle, and that leads to ischemia. If not treated, there's going to be now myocardial infarction. C is saying list and describe two common complications that can occur within the first 24 to 48 hours following an acute myocardial infarction. Why do these complications arise? When blood is not going to the heart, in the first 1 to 2 days, there will be arrhythmias, and then there can also be cardiogenic shock. You know, shock is a condition where there is no enough blood supply. Here is the pump, and here is a hose pipe. So, what can cause shock is a lot. Anything that is going to reduce the size of the blood vessel can reduce the amount of blood moving out, and that can cause shock. Anything that will affect the actual pump can also lead to shock because it can reduce the pumping action. Okay. So specifically because the heart is being affected, this person has got MI, cardiogenic shock happens. The heart can't pump blood, and that leads to hypotension. Now, for the blood vessel, what leads to shock is not constriction but dilatation, because once the blood vessels have dilated, that causes a drop in blood pressure. And so, because of this hypotension, there's going to be no enough blood taking oxygen and nutrients to the organs, and so there will be organ failure. Okay, so these are the common complications that can occur. And then what other causes besides atherosclerosis could lead to ischemic heart disease? Provide at least two examples and briefly describe how they can result in ischemia. So besides atherosclerosis, anything else that can cause that can cause ischemic heart disease? You have got the coronary artery spasm. This is where the coronary artery ends up just contracting like that. A sudden and temporary tightening of the muscles within the wall of the coronary artery. This can reduce or block blood flow to the heart, and that can lead to ischemia, and later on can lead to myocardial infarction. And emboli can as well lead to this ischemic heart disease, because if the thrombi breaks free, starts to move in the blood, that's now an emboli, and it can go and reach to the coronary arteries, and then it will be able to block blood flow to the heart. That leads to ischemia and myocardial infarction. Okay, just a moment. Is my screen visible? Can we see the screen? Okay. Hope we've gotten about question D. And then E of the question, discuss the concept of time is muscle in the context of acute myocardial infarction management. How does this concept influence treatment priorities? So you can answer this question just by looking at it. Time is muscle. This emphasizes the importance of treating the condition, the acute myocardial infarction, there and then, or as soon as possible. Because the more time you waste, the longer the more the heart muscle is deprived of the necessary nutrients and oxygen, and the greater you destroy the muscles to a point of irreversibility. Okay, so this principle is important in that it influences treatment priorities. For example, rapid reperfusion, ensuring timely reperfusion of the occluded coronary artery through thrombolysis or percutaneous coronary intervention to restore blood flow and limit myocardial damage. If a blood vessel has been blocked, let's say there's a thrombi, emboli, atherosclerosis, give something quickly that is going to break that thing. If it is a thrombus, give thrombolytics to have the heart reperfused. And also early intervention, encouraging patient to seek immediate medical attention in order for you to be able to restore blood supply to the heart. Because the more time wasted, the more problems worsen. Number F, describe the morphological changes that occur in myocardium after an infarction. What changes would you expect to see within the first week post-infarction? Okay. So this is from you. You can as well just read up. I posted the notes on the drive on the necrosis and apoptosis because this is from that topic. So you can just read up that what are the events that happen during cell injury in the first day, second day, and as the days progress. So after a myocardial infarction, the heart muscle is going to start dying, but it doesn't just do it there and then. That is why, say if someone has died, right, and then you look at the heart, you expect that they died from myocardial infarction. You're just looking at the heart is going to tell you how long they have had the condition. Within the first 24 hours, there's going to be coagulative necrosis of the myocardial cells. They are going to start dying. And then you'll be able to see wavy fibers. The myocardium is going to become, the fibers will be wavy, like you'll be able to see the muscle tissue like that. There's also going to be demand hemorrhage because there is an accumulation of fluid. And then, so the question is asking us for to see within the first week post infarction. So this is the first 24 hours. Within 1 to 3 days, there's now going to be acute inflammation. Neutrophils are what you are going to be able to see. And then as the condition continues, necrosis is going to continue, coagulative necrosis is going to continue, and the affected area is going to become more defined. You can now clearly see, okay, this part has been affected. By third day to seventh day, there's now going to be chronic inflammation starting to happen because this was acute. That's the neutrophils. And then macrophages, because chronic inflammation is now happening, will start appearing. Okay. And these guys will replace the neutrophils and they'll begin phagocytosis of the dead cells and the debris. And then because this is chronic inflammation, granulation tissue start forming. This is where you have got your cells, the live cells, the dead cells, and then you are going to have these giant cells also. These are basically the macrophages fusing. Then you are going to have them surrounded by these fibroblasts like that. That's a granuloma that is forming by the end of the first week. Number four, a 31-year-old woman presents to her gynecologist for a routine checkup. She reports no significant symptom but mentioned she has been sexually active since her teenage years with multiple sexual partners. Her medical history is unremarkable and she has no known family history. So, no known family history of cancer. She reports a consistent use of barrier contraceptive but admits to occasional relapse. A pap smear was performed as part of a routine screening. Cytology results indicate a low grade intraepithelial lesion. A follow-up colonoscopy showed white patches in the transformation zone after applying Lugo solution, suggestive of cervical dysplasia. Based on a pap smear result, which is she has got low-grade squamous intraepithelial lesion, which grade of cervical intraepithelial neoplasm does this patient most likely have, and what does this imply in terms of how bad the condition is? I think I didn't finish that statement. Okay, how does it imply? So looking at what they have, this is low grade squamous intraepithelial lesion. When you are classifying cervical cancer, you look at the CIN, the cervical intraepithelial lesion. So CIN1, CIN2, you have got CIN3, which is also known as carcinoma in situ, and then you have got cervical cancer. So CIN1, this one is a low grade type, and then the rest of these are high grade. Okay. So based on the which grade of cervical intraepithelial neoplasm is this? So because this is low grade, that is CIN1. And then, and what does this imply? So what does CIN1 imply? When you look at this female cervix, this is a uterus this side and that's a cervix. You have got the transformation zone where you are having the vagina this side, the cervix that side. If you get just a transformation zone, you look at it, it has got cells from the basal end going upwards to the apical end. CIN1 means that the cells that are dysplastic, there is dysplasia, abnormal division of these cells. Only the lower one third, right? The lower one third from the base of the cells have been affected, are dysplastic. So there is just mild dysplasia of the lower one third. What is the primary etiological agent responsible for cervical intraepithelial neoplasia? Which type are most common associated with high risk cervical cancer? So the etiology is HPV, and the guys that are responsible for the high risk HPV, you have got 16 and 18 being the major ones, but you also have 31, 33, 35. So these ones cause what we call, these are high risk HPVs. The low risk, you have got things like 11, HPV 11, and the others. Discuss the risk factors in this patient's history that might predispose her to infection with high risk human papillomavirus. So, what are the risk factors that this woman has that can predispose her to infection? You know, HPV likes interacting with that part where there is a change of epithelium from the columnar epithelium of the cervix to the squamous epithelium of the vagina, and that is the squamo-columnar junction, also known as the transition zone. So what are the risk factors that this patient has? So number one, she's sexually active. That is one risk factor for actually getting infection by HPV, cervical cancer. Number two, multiple sexual partners. Okay. Number three, she's not just sexually active, but since a teenage, so early sex, because early the squamocolumnar junction is inside the vagina, and so what happens is that any sexual contact, normally the men carry HPV, but it's not causing any infection. But once the female carries it and it interacts with the squamocolumnar junction, it will start causing dysplasia there. Okay. And then what other thing? She has no history of cervical cancer, so that one no. And then uses contraception, relapse, a pap smear performed on a routine. Okay, so these are the main ones that we can mention here, but there are many risk factors of cervical cancer, though history there is no. Yes, please. Oh, yes, because that's also one of them. Yes. And so the where is that? The barrier contraception admits not having occasional relapses. So that is going to be a fourth one. Okay. These ones, these other things is diagnosis. So that is also part of that. And what are other risk factors that we can mention? Because cervical cancer and breast cancer are high use that we need to know. Sexual history is there, multiparity, not parity, sorry, but multiple sexual partners. About multiparity, that one will be talking about other things. Beginning sex at an early age, and then has a partner who has got multiple sexual partners, or with a woman that has got cancer, and also smoking, especially to predispose someone to having the squamous cell carcinoma. Because you know the way the squamocolumnar junction is. Let's say this is the squamous junction. This is the vagina this side. This is the cervix. The cervix has got columnar epithelium. Vagina has got squamous epithelium. So meaning that cervical cancer can affect the columnar epithelium. That will be the columnar epithelial cancer, and then the squamous. So I've got squamous cell carcinoma, and then you have got adenocarcinoma, which is affecting the columnar cells. Weakened immune system by other infections, promiscuity, having a lot of sexual partners, several pregnancies also. Okay, multiparity and multigravida is also going to cause this. So this is opposite, because for someone that for breast cancer, the more children you have, multiparity is actually an advantage. It reduces the risk of you getting breast cancer, but it increases the risk for getting cervical cancer. That is because of estrogen. Okay, estrogen in breast cancer is one of the things that will increase the risk of getting breast cancer. But estrogen is opposite for cervical cancer. That is why for people that are pregnant, the levels of estrogen at least are a bit low. That's why they are better. They will not more likely have the breast cancer. History of other STDs as well can be factors that can cause. Is there any other contribution or addition on what we've discussed so far? Okay. Number D is saying, explain the potential progression of her cervical intraepithelial neoplasia if left untreated. What are the estimated percentages for progression to invasive squamous cell carcinoma? CIN1, IN2, CIN3. So look at this. Here is HPV. And HPV is going to interact with the squamocolumnar junction. So depending with which part, if it is on the cervical end, this patient is going to have the because the cervix end of the squamocolumnar junction, there's columnar epithelium. So that will be the adenocarcinoma. And then if it is on the vaginal end, that is going to be squamous cell carcinoma. But these ones are non-invasive. We actually call them carcinoma in situ. Adenocarcinoma in situ and this squamous cell carcinoma in situ. This is CIN3. And then once these guys, dysplasia continues to happen, they can now lead to invasive adenocarcinoma. This one will lead to invasive squamous cell carcinoma. Okay. But before you can have the carcinoma in situ, which is the cervical intraepithelial neoplasia, just the dysplasia, the abnormal division of cells. Before you can have that, you are actually going to have first a point when there's just dysplasia. So you are going to first start with a, so we are talking about the cervical intraepithelial dysplasia going into cervical cancer. CIN1, there is just dysplasia of the lower one third of the squamocolumnar junction. So the percentage of it going into cancer is very low, actually just between 1 to 2%. Very low. For CIN1, 2, this is where now one third of the cervix has been involved, starting from the basal end. The cells are dysplastic, and so the chance of it going into the invasive squamous cell carcinoma increases a bit to 5%. And then CIN3, which is the carcinoma in situ, here the entire thickness of the squamocolumnar junction is dysplastic, but then there's no metastasis. So it is still not considered the invasive squamous cell carcinoma because there's no metastasis. The chance of this progressing into cancer is much higher, which is like 20%. And then you can now have the last, which is now the cervical, the squamous cell carcinoma, or the adenocarcinoma, which is the invasive one. Hope this is okay. Please, if there's any question or a contribution, be free to do that. Number E is saying, in addition to pap smear and colposcopy, what other diagnostic method could be employed to monitor or confirm cervical dysplasia and determine the lesion grade? So you can do the HPV DNA testing to detect the presence of the high risk HPV, and then you can as well do a biopsy. You are going to get a sample, and then you get to look at how much has been affected, right? So biopsy and the HPV screening. If this patient, CIN, were to progress to squamous cell carcinoma, describe number one, the possible local spread. The possible local spread, and then number two, systemic complications that could arise. So possible local spread, if this the cervical intraepithelial neoplasia is supposed to go into squamous cell carcinoma, they can be local spread. So nearby structures like the vaginal wall and also the parametrium, these walls of the uterus can be affected. The pelvic side wall can also be affected. Lymphatic spread can as well happen. The cancer can go to regional lymph nodes. So this is a possible local spread via the lymphatic system. And this is a regional, like the like the pelvic lymph nodes, the para-aortic lymph nodes. Like if you have got this aorta, you have got lymph nodes which are near the aorta. Those are the para-aortic lymph nodes. So that's a possible local spread. And then for systemic complication that can arise if the cervical epithelial neoplasia goes into the invasive carcinoma, there can be metastasis. Now, this is penetrating borders, right? This is where distal organs are involved. The lungs, the liver, the bones can be involved. Like because of that, that can lead also to organ dysfunction because of the involvement of these vital organs. For example, the respiratory system can fail, the liver can fail, there can be bone fractures. So those are the possible complications. Number five, you are a newly qualified doctor at the university teaching hospital, and while on call, you receive a 35-year-old man with a family history of colon cancer. It gives a history of rectal bleeding. You order a colonoscopy among other tests. So there is a rectal bleeding. Take note of that. Post colonoscopy, it shows you a report that says several small pedunculated polyps and two large ones were seen in the right colony, that is the ascending colony. An ovate cancer is not seen. History of two large polyps removed at colonoscopy confirms that they are adenomas. Okay. List two common syndromes that could predispose this patient to colon cancer. So conditions that can predispose one to colon cancer: familial, adenomatous, polyposis. This is a condition that is hereditary where you have got a lot of adenomatous polyps. Polyps is a structure that is coming out like that. Okay, so those are the ones. And then you can also have what we call the Lynch syndrome. It is a hereditary non-polyposis colorectal cancer. So this is an inherited disorder also that increases the risk of many types of cancer, including the colorectal cancer, Lynch syndrome. List at least two genes that are abnormal or mutated in the above two conditions. So I've got the APC gene, it's mutated gene in familial adenomatous polyposis. You can look at the different genes that are affected in each type of cancer. I've posted in the Google Drive for pathology, genopathology on neoplasia. I've posted the notes on neoplasia there. And then you can look at these different genes for the different conditions. You also have the MLH126 PMS2. These ones, there's going to be mutation in these mismatch repair genes, and this is associated with the Lynch syndrome. So the MLH1, MSH2, MSH6. So list at least two. What is an adenoma? Adenoma is a benign tumor and it arises from glandular epithelium. So that is the basic thing. Benign tumor of the that arises from glandular epithelium. It can occur in different regions. Though these guys are benign, they have the potential to become malignant, just like we know nearly all benign tumors can become malignant. List two types of adenomas. We have got tubular adenomas. They are characterized by tube-like granular structures. Okay, like they are like tubes. Remember this guy, first thing is a benign tumor and then it's forming like more like a tube, and then you have got the villus adenoma where you have got finger-like processes, and these ones have got, the villus one has got a high risk of becoming malignant. What is the adenoma carcinoma sequence? Adenoma carcinoma sequence. So this is a stepwise process in which normal colonic epithelium can progress to an adenoma. This is a benign tumor, like a benign polyp, and eventually becoming a carcinoma. That is the sequence. That is the adenoma carcinoma sequence. And there can be accumulation of genetic mutations, which is going to be involved in this process. For example, the APC gene mutation, which will lead to the formation of small adenomas. There's the CRAS gene mutation that promotes large adenomas. P53 gene mutation that leads to the development of carcinoma. Now P53, this guy is a tumor suppressor gene. So if there is a mutation, there's not going to be any separation of the tumors, and so there's going to accumulate. There's going to be tumors, tumors, and tumors. In general, what diet predisposes one to the development of colon cancer? Red, a diet that is rich in red and processed meat. Low fiber, high fat. This one is as there is increased risk of getting colon cancer. Large amounts of alcohol, low intake of fruits and vegetables also do contribute to that. So technologically, the red and processed meat, the fat, the alcohol. Number 6, Miss Sarah Mumba, a 62-year-old woman, presents to the clinic after a fall that resulted in wrist fracture. She mentioned that over the past few years, she has noticed that she has lost some height and has developed a slight stoop in her posture. Miss Mumba went through menopause at age 48 and has not taken hormone replacement therapy. She reports a family history of osteoporosis, as her mother had multiple fractures in her 70s. Her diet is low in calcium rich foods, and she spends most of her time indoors. Look at that. You can relate, right? Limiting her exposure to sunlight. Additionally, Miss Mumba has been a smoker. Look at that. For many years and rarely exercises. Look at that. All these things are actually risk factors for osteoporosis. Define osteoporosis. It's a chronic condition. Please, chronic, not acute. And there is actually weakness in bone, and they become fragile, more susceptible to fractures. And there can be a lot of causes. It can be due to decreased bone mass and density, resulting in imbalance between bone resorption and bone formation. What happens? You have got two main cells, osteoblasts. Okay, let me not go ahead of myself. Take note that there's an imbalance between bone resorption and bone formation. That's also important. Identify 4 risk factors for osteoporosis, present in Mrs. Mumba's history. So she is postmenopausal. And besides that, after postmenopause, she didn't take estrogen because estrogen is going to be important in bone. And then there's also a family history, as her mother also had multiple fractures. It also tells us that there's low calcium intake and also smoking, right? All those predispose. And she also lacks exercise. She doesn't exercise and she is mostly indoors, you see? So she has a low exposure to vitamin D. Stage 2 common forms of osteoporosis. Osteoporosis can be primary or secondary. Primary, when you say something is primary, it means that it's happening by its own. Secondary, it means that someone has got another disease and that is causing that condition. So, for example, just after menopause, you expect someone to have osteoporosis, actually, that they are not taking hormone replacement. And then so that is a type 1, that's postmenopausal. And you can have the type 2, which is age related or senile osteoporosis. That is all primary. There's no really cause, it's nature. The secondary osteoporosis occurs due to other medical conditions that affect bone metabolism. You can think of one. Think of the kidney, because the kidney produces what we call 1-alpha hydroxylase. That guy is going to be important in the absorption of calcium, and calcium is important in bone. So if you have kidney disease, you're expecting to have problems here. Also GI diseases, where they're affecting absorption, right? List 4 things involved in the pathophysiology of the 2 forms mentioned in C above. So, what are the things that can cause primary and secondary osteoporosis? Number 1, hormonal changes. In primary osteoporosis, there's going to be decreased estrogen levels, and that leads to decreased bone resorption because estrogen is important in. So this leads to increased bone resorption because estrogen is important in reducing bone resorption. Bone resorption is breaking bone, so estrogen is important in reducing that breaking of bone, promoting the formation of bone. Aging also, like in senile osteoporosis, which is the type 2 primary osteoporosis, is the natural aging process that results in decrease the bone formation and increase the breaking of bone. So aging. And then medical conditions, for example, hyperthyroidism. You know why? For hyperthyroidism, you have got the thyroid gland, and this thyroid gland will produce the thyroid hormone that promotes really the breakdown, promotes more of these catabolic processes that increase in formation of energy. Chronic kidney disease, as we said earlier, And then medications, for example, corticosteroids can lead to secondary osteoporosis by increasing bone resorption and decreasing bone formation. Corticosteroids, fluconazole. Briefly describe the pathogenesis of osteoporosis in terms of the receptor activator for nuclear factor kappa, which is the rank, and then the receptor activator for nuclear kappa factor kappa for nuclear factor kappa beta ligand. So they are rank L. So I've got a ligand and then the receptor itself. So what happens is this. Let's describe it nicely. Here is me, who is, let's say I have got low calcium. For whatsoever condition, I've got for whatsoever problem. Maybe I'm not taking in enough, or I can't absorb enough, or maybe there's liver or kidney disease. The kidney is excreting a lot of calcium, or any other reason. What happens is that low calcium will stimulate the parathyroid gland to produce the parathyroid hormone. Parathyroid hormone has got effect on three tissues. It will go to the kidney. On the kidney, is going to cause three things. Number one, it is going to cause excretion of phosphate. So that leads to what we call phosphaturia. So excretion of phosphate, because if phosphate is in blood, it will bind to calcium. And once calcium is bound to phosphate, the body records that it has low calcium. And so that is what we are trying to avoid. So remove what holds you. Please remove what holds you. Even in your academic life, remove what holds you so that you can be free. Remove wrong relationships and everything that is disturbing you. Besides that, on the kidney, parathyroid hormone is going to cause absorption or reabsorption of calcium back into blood. Again, on the kidney, parathyroid hormone stimulates the activation of 1 alpha hydroxylase. 1 alpha hydroxylase is a good guy. What it does is converts calcidio to calcitriol. Calcidio is also known as 25 hydroxyl 25, what's the other name? 1 comma 25 dihydroxycholecalciferol. Okay, 25 hydroxycholecalciferol is a calcidio. Calcitro is 1 comma 25 dihydroxycholecalciferol. That is the active form of vitamin D. And this active form now is going to work on the intestines. That's indirect. So PTH has got indirect action on the intestine. This calcitriol that is going to stimulate the intestine to absorb, to increase absorption of calcium. PTH has got also an effect on bone. And this is our interest when it comes to osteoporosis. What happens on bone is that PTH, parathyroid hormone, works on those cells that break down bone, and we call those as the osteoclasts. Okay, the osteoclasts. So we have got this guy here, the osteoclast. What happens that once PTH has bound on osteoclast, it is now osteoclast break down bone. All right, they will break down bone, but in the initial way, but before then, I've put here on the osteoclasts. Okay, so osteoclasts are supposed to be breaking down bone, and once you break down bone, what happens that you are going to release calcium. But parathyroid hormone, the effect is not on the osteoclast. Instead, it's on the osteoblast. Can you see this, guys? Osteoblast. This is where parathyroid hormone binds. Parathyroid hormones build bone. That is why the initial effect of full agonists for parathyroid hormone are used in the treatment of osteoporosis, because they will initially be working on osteoblasts, and osteoblasts will now do what? Osteoblasts will now build bone. But the long-term effect of parathyroid hormone is once they attach on the osteoblasts. Osteoblasts will start releasing cytokines. Those cytokines, look at this. Can you see these to my blue things? Yes, cytokines. So you have got prostaglandin E2, you have got parathyroid hormone, tumor necrosis factor alpha, interleukin 1, interleukin 11, interleukin 17. So these cytokines are released, and then they are going to bind on what? They are going to bind on the osteoclast. But then there's you have got a ligand, because these guys that are produced here, they are known as the rank ligand. These cytokine, they are rank ligand. These ligands or hormones, that's the other term, they are going to bind on their receptor. The receptor is on the osteoclasts. That is the rank receptor. Once the osteoclasts have been stimulated by the rank L, they will now mature into the mature osteoclasts, which now begin to break down bone. So that is the effect. Okay, that's the effect. That's how. So the problem in osteoporosis is there is actually imbalance between bone resorption and bone formation. So the rate at which bone is going to be broken down is more than the rate at which bone is being formed. So that's the problem. And another important thing you need to know about bone here is there is what we call osteoprotein, protegerine, OPG. This guy is a decoy receptor which is produced by the osteoblasts, and it actually binds to the rank ligand. And when it binds to the rank ligand, it prevents it from interacting with the rank receptor. So it prevents it from activating the osteoclast to start cutting bone. But once there is a disturbance of this OPG, is not there, it means that rank L will be unnecessarily attaching to rank. And then there's activation of the osteoclast, and then there's more breaking down of bone. Does this make sense? Are we okay? Okay, question F. We'll end on F then. Outline the management plan for Miss Mumba, including lifestyle modifications and dietary changes. So you just look at the problems. You can give some dietary changes. So you increase the intake of calcium, rich foods, okay? Because we've been told that this person doesn't take calcium rich foods. And then we were told that they're also inactive. So encourage them to exercise. We are told that they are smoking, encourage them to stop smoking. We are also told that they are mostly indoors, so encourage them to spend some time in the sun to have exposure to the vitamin D.